continue with our tradition of data breakfast, even in these very challenging times. And I'm very happy that we have today a very prominent speaker who is at the forefront of what's of the COVID-19 happenings in South Africa. Before I introduce you to Richard, I would like briefly to review a few of the webinar rules, so that, because we might all be new to this. Yeah. On the right-hand side of your screen, there is a chat facility, because all of you are muted and can't reach us via voice. So you're welcome to make use of the chat facility to ask questions, or that Richard might be able to answer towards the end of the talk, or interactively if he so wishes. Okay. Sorry, I forgot one thing. Sorry, I do it for the first time, so I also a little bit a newbie in this game. I forgot to introduce myself. Yeah, my name is Francesco Petruccione, and I started this data breakfast initiative more than a year ago as part of the big data and informatics initiative of UKZN. Yeah, and I just want to make a remark. You know, we've been speaking in this breakfast series mostly about topics related to the fourth industrial revolution. Yeah, and I think we just needed a little tiny virus to accelerate our embracing of all the tools of the fourth industrial revolution, like we are using here today. Yeah, and I was really amazed that the whole of UKZN managed to go completely online in just about a week, which is a sensational performance, I think. Under normal circumstances, it will probably have cost us 3-4 years, if at all. Yeah? So a big thank you to everyone who made this possible. Okay, let me then now introduce you, Richard, because you're not here to listen to my chatting. Richard Lessells is an infectious disease specialist at KRISP, which is a unit of UKZN. He trained as an infectious diseases and internal medicine physician in the UK, and he has a PhD from the London School of Hygiene and Tropical Medicine. He has been conducting clinical and population-based research in HIV and TB in KwaZulu-Natal since 2007. He's currently deployed to the UKZN COVID-19 war room and is supporting the local response to the epidemic. And I must say that from personal experience, I know that this COVID-19 team of UKZN is doing really exceptional work. Richard, now it's over to you. If you would like to share the screen and start your presentation, we are all 102 of us looking forward to hear your talk.
Thank you very much, Francesco. And I hope everyone can hear me well. I see actually it's not just the chat box, there's actually a specific question and answer box. So I will try and keep my eye on that, but Francesco, feel free to interrupt me, and if you think there's a question there that we should address as we're going through rather than at the end.
Yeah.
I plan to talk for just about 30 minutes so that we do leave time for discussion and addressing some of the questions that come up. As Francesco said, this is really a remarkable epidemic that's going to change us in lots of ways as society and as academics and how we operate and live our lives, I think. So really today what I wanted to do was just to give a bit of a bird's eye picture of where we are globally and locally, and just really what I'm going to do is present back some of the beautiful data visualization and things that the big data group are producing on a daily basis. I'm going to present back some of their work and just try and tell a story around that. So I want to just start by going back. It's now almost exactly 3 months ago, while we were all relaxing in between Christmas and New Year, that this notification, or what's called a request for information, came out. And many of you are probably not familiar with this website called ProMed, run by the International Society for Infectious Diseases. But essentially, this is where people around the world can post situations that they're noticing locally to get global attention. And this is actually where many infectious diseases outbreaks first start or first come to attention. So if you remember the West African Ebola outbreak, this was similar. Somebody posted on ProMed that they were starting to see case of unknown illness in West Africa. So you can see here, this was posted on the 30th of December, and essentially it was saying that they had a cluster of people with undiagnosed pneumonia in Wuhan, China, and that they had done some tests, but were waiting for results. So not yet 3 months ago. Just so that we are all familiar with the terms that we are now using to describe what this infection and this virus has become. The disease that we talk about COVID-19, and that is coronavirus disease. And the virus we term SARS-CoV-2, and that stands for severe acute respiratory syndrome related coronavirus 2. So just to bring you up to the present day, as I say, 3 months ago, we didn't know this virus existed, this disease existed, and now it's spread to virtually every country in the world. I actually had to look yesterday to see how many countries in the world there are, because I wasn't sure how many we had to still go after we got to 175. And essentially there's only about 10 or 20 countries that are unaffected. And if you see that's countries like DRC and South Sudan, where probably they don't have any testing capacity to diagnose the infection. We've just gone over the 500,000 mark of confirmed cases. And many of you, if you've seen the news last night or this morning, will be aware that the United States has now become the country with the most number of cases. So it's overtaken Italy and China. The epidemic is still growing quite rapidly in the United States. We're now, if we're not already, we're almost at 25,000 deaths as a result of this infection. So really quite remarkable, as we said, that this was something we didn't know about 3 months, and this is where we are now. And I think for those of you who know about infectious disease epidemics and things, this was something that we were aware could happen at some stage, but countries and globally, we were prepared for it, but obviously countries were at different levels of preparedness. And I think what we've seen is that even some of the countries that would have been thought to be well prepared have struggled to deal with this epidemic. This is just a graph showing the simple growth globally of the epidemic. So on the x-axis is just time from January the 21st, when we kind of first were able to confirm the cause of this new disease, right up until yesterday. And you can see just a classical kind of exponential growth here, this slightly odd step is just an artifact from changing case definitions in China. And I think what's really remarkable here is if you look at the time taken to get to 100,000 cases was about 60 days or so. To the second 100,000 cases was 11 days, then 4 days, then 2 days, and now essentially 1 day to get an extra 100,000 cases. So just illustrating that exponential growth. Here's the first of Francesco and his team's graphs, which is showing us what's happening in South Africa. And here, again, on the x-axis, we have time, and here we're starting from the 5th of March. So just over 3 weeks ago yesterday, when the first case was reported in South Africa. And we've now reached just under 1,000 confirmed cases. So by confirmed case, we mean somebody who has a positive laboratory test result for the virus. You can see in the insert here the provincial breakdown. So while KZN was the province with the first couple of reported cases, Gauteng has kind of accelerated past and is now the province with the leading number of infections, followed by the Western Cape. And slightly worryingly, just something we can maybe come back to in discussion, you can already see challenges with the data and the quality of the data here in South Africa, that we have a number of cases where we don't even know the province, and it's hard to know why that's happening, because the system should be able to tell where tests are being done, which labs they're coming from at least, even if clinicians like myself are not filling in the forms properly. The system should be able to identify which province cases are coming from. So just something that we can pick up on later. Again, you're essentially seeing exponential growth here, and something that we talk about a lot is the doubling time, and the doubling time is essentially just the time it takes for the number of cases to double. And what we're seeing at the moment in South Africa is that somewhere between 2 and 3 days. So for example, you see here from 200 cases roughly to 400 cases takes just 3 days. Just at the bottom here, just showing that, as many of you will be aware, the first lot of cases were all in people who had returned from traveling overseas, the majority of those to European countries. We didn't see early on in February, we didn't see any cases coming from people that had traveled from China. And one thing to discuss is whether we believe that there were no cases that came from China, or whether we may have missed cases then, and that's contributing to the rapid spread of the epidemic now. But essentially here, almost 2 weeks into the national outbreak here, we started to confirm cases that had not been out of the country, but had been in contact with cases in the country. And then subsequently, we've seen cases where there is no clear epidemiological link with another case. So that's where you can't definitively say that this person has been in contact with a known case. And that tells you that there's transmission, that there's spread in the community to some degree, that people have been exposed just going about their normal life in the community. This is a graph, I think, from Hamid in the group. And this is really just telling us that we're already quite worried by the previous graph, that we've now reached almost 1,000 cases, and I'm sure we'll go over the 1,000 cases today. But it's just a reminder that even what you're seeing there is not giving you an accurate reflection of the number of people in the country that are infected at the current time. And just to explain why that is, the cases that are reported today, so the numbers that will come through later today at some stage, they essentially reflect transmission events, or they reflect people acquiring the infection roughly about 7 or 9 days ago. So the middle to end of last week. And that's because from the time that you're infected with the virus, it takes on average about 5 to 6 days until you develop symptoms, until you become unwell with the infection. And at the moment, it's then taking around about, on average, 2 or 3 days to get a test done and to get the test result back, and possibly even longer than that at the moment. So this is essentially just showing, if you make that assumption to say that transmission has been continuing while we see this kind of increase in case numbers, we're actually closer to something like 4,000, 5,000 people who are currently infected with the virus. So most of those will not yet be showing symptoms, but they are infected with the virus. And obviously they then have the potential to further transmit the infection. Again, this is Francesco's team's lovely graph, and there's many versions of this. I think one of the things that this epidemic has highlighted is the kind of amazing data visualization tools that we have now, and the kind of ability to really give us great graphics to understand the basics of an epidemic like this. And so just to orientate you here, this graph is showing a few different countries and showing the trajectory of the epidemic. So here again on the x-axis, you just have time, you have the number of days since the 100th case was reported in the country. And then on the y-axis is just the number of cases on a logarithmic scale. Now, the reason that it starts at the 100th case and not the first case is really because once you've got past 100 cases, as we saw in South Africa's example, in most cases, you're fairly certain that there's already transmission happening in the community, at least locally, somewhere in your country. So it just gives you a picture of the trajectory once you're sure that transmission is happening in the country. And you can see the thing to note here is really the remarkable similarity of many of the countries. And here we see Italy, we see Spain, we see the United Kingdom, all following a roughly similar trajectory here. And we see South Africa here in the bold black line. And we're essentially, this is now a day or two out of date, but we're essentially following this similar trajectory. And here you see this marker line saying that this is essentially a 33% daily increase. So all these countries are sitting somewhere close to that line. You can already see that there's a few countries where things are a little bit different, and the key ones here are towards the bottom of the graph, where you see Singapore and Japan, and you see them really on a different trajectory. And you see that they managed to really slow down the rate of growth of the epidemic. And we'll come back to just discussing how they did that. But it's just to show that there aren't that many countries that sit differently here from this kind of basic trajectory that we see. And I think one of the things that in simple terms tells us is that, as expected, the virus behaves in much the same way wherever the virus is. And that shouldn't be a surprise to us, but for some people that still seems to be a surprise that countries are following a similar trajectory once the epidemic reaches them. This is now just showing the trajectory across the different provinces of South Africa. And here it's really a little early to read too much into these patterns. And the thing that we don't have here is really any data to know how much testing is happening by province. And so we don't know what the denominator is for the number of confirmed cases in each province. But just to kind of note that there seems to be some difference. Here in green is KZN. As we said, we reported the first case, but seem to be on a slightly different trajectory to Gauteng and Western Cape in the orange. But whether this is real or whether this is an artifact of testing access, testing behavior, I think remains to be seen. And so this is one graph that is going to be interesting to follow as the number of cases increases over the next few days. This is not one of the big data team's graphs, and that's because, as you're probably aware, we haven't yet had a death in South Africa. But as well as following the number of confirmed cases, it's important to follow the deaths. And that's because we know that the number of cases is dependent on how much testing is being done. And one of the things we're seeing in this epidemic is quite a wide range across countries, even amongst high-income countries, a wide range in how much testing they're able to do or how much testing they're choosing to do. And so deaths, of course, is ultimately what we want to prevent. And so just gives you a slightly different picture of the epidemic. But again, this is a little bit of a messy graph with more lines. But again, it's just showing you that many countries are following a similar trajectory here, where the number of deaths is doubling somewhere between every 2 and 3 days. But you can see here a couple of outliers again. And I think Singapore is not on this graph of deaths. But here you can see Japan again and South Korea. And again, you can see clearly on a different trajectory where the number of deaths was doubling approximately every week. And again, this is something that we should be learning from to see these are clearly on a different trajectory. So what was it that they were able to do in those countries to take their epidemic on a different trajectory? Just to note, the stars here are just highlighting when people essentially locked down the country or got to the stage that we got to last night of the much more restrictive conditions on human movement. And I think the key thing there is just to recognize that South Africa has taken a very bold move of locking down, really when we haven't had any deaths. You can see here that many countries are locking down after 200, 300 or more deaths. Italy was kind of later here that they locked down after 800 deaths. The United States hasn't yet really fully locked down, and it's now on a varying trajectory, both in the number of cases and the number of deaths. You can see it kind of accelerating here in the United States. There was a question at the beginning on the Q&A, and I'm afraid I can't see the Q&A window now that I'm sharing the screen. But there was a question about how severe this infection really is, because there's a lot of very different stories as to from one side that it's a very mild infection to the other. It's an extremely severe infection. And the reason there's different stories is because there is a bit of variability in what we call the case fatality rate across different countries. So the case fatality rate, in very simple terms, is just the proportion of people with the infection who die. And just to take the two examples here, Italy, that many of you will be aware of, that's facing a very severe epidemic at the moment. The proportion of cases in Italy that are dying is sitting around 5%, or possibly even higher now. This is a little bit out of date, this graph. And you can compare that to South Korea, where the mortality is sitting at less than 1%. And you can see this variability by country. And so what this reminds us is that although we said the virus behaves in a similar way in wherever it is and whichever country it's in, the impact that the virus has obviously depends on us as humans, and depends on our behavior. And I think that this difference between South Korea and Italy kind of highlights some of the differences in the approach taken. So South Korea essentially managed to do very wide-scale testing on a population level. And so they were detecting probably most of the cases that were truly infected in the country. And so their mortality rate looks a bit lower because they were detecting a lot of milder cases, possibly even cases that had no symptoms at all, or asymptomatic cases. And so this you then end up with a relatively low mortality. Italy, very rapidly, the health system became overwhelmed, and the testing was concentrated in the very sick people that were reaching hospitals. Italy has a demographic profile with quite an elderly population, and they're at higher risk of mortality. And so their overall mortality looks worse when you take it as a proportion of the cases. So we don't yet know where South Africa will sit here. As we said, we haven't yet had a death, so it's far too early to understand where we'll sit in this kind of range of fatality rates. Just to illustrate this point, that the severity of the illness and the risk of dying from the infection is quite heavily determined by the age of the person. And this is data from China, from the first wave of the epidemic here. And this is just showing the different age categories here. and showing the risk of dying amongst people of that age. And you can see for people under 50, certainly the risk of dying is very low. And it starts to climb once you get above 50, certainly above 60. And by the time you're above 80, you have around a 1 in 7 chance of dying from the infection. I could show you a very similar graph from Italy that is essentially finding much the same relationship. Having said that, I think in the first few weeks and months of the epidemic, we were saying that this was very clear that young people don't get severe illness at all, and young people don't die from the infection. But I think the last couple of weeks, we've seen both in the United States and in Europe, an increasing number of younger people being admitted to intensive care and a small number of younger people dying. And this is even younger people without comorbidities, without other chronic illnesses that put them at risk. And so, although this relationship with age is very clear, we shouldn't be complacent here that young people are completely protected from severe illness and protected from death. This is just showing you then, when we're thinking about South Africa, one of the first things that we're thinking of is what is the population structure here and how does it compare to these other countries that are badly affected by the epidemic. So here's what we call a population pyramid of Italy. And here you're just showing the proportion of the population in each of these age bands. And you can see that Italy has quite an elderly population. Just looking then at South Africa, you can see clearly a very different structure to the population. That our population is much more heavily weighted amongst the younger people. Just to illustrate this, if we think about the population aged over 60 years, in Italy that's almost 1/3 of the population, whereas in South Africa it's only about 8% of the population. So, as I said, we don't know to what extent this is going to affect what we see in terms of the death rates in South Africa. One of the big unknowns that we have is clearly, although we have a younger population, a lot of this younger and young adult population are infected with HIV or have TB or have previously had TB and have damaged lungs as a result of their TB. And we still have no real idea how those diseases, HIV and TB, are going to affect how COVID-19 behaves. And so that's something that we want here to very rapidly get a grasp on, because it's going to be a big factor in how the epidemic goes here in South Africa. So that gives us a picture of where the epidemic is, but I want to just turn now to how the epidemic is spreading and think about the responses to the epidemic and what we're trying to do with the responses and why we're now in this situation of lockdown. So those of you who are following the epidemic very closely have probably been hearing lots of epidemiological terms and trying to get your heads around lots of terms that you wouldn't otherwise have had much dealings with on a day-to-day basis. And one of these terms that you may have come across is the basic reproduction number, or what we call the R0. And essentially what this number is is telling you on average how many people will one person with the disease infect. And so when we look at this new infection, we have estimates of what we think the basic reproduction number is, and we think it's sitting somewhere between 2 and 3. So what we're saying is, on average, each person with COVID-19 will infect 2 or 3 other individuals. And this is just a pictorial of that here, showing the infected case in the center, how many other people in the population around them they are going to infect. During this epidemic, there's been this kind of constant need to compare it to other things that we're more familiar with, other epidemics that we're more familiar with. And the thing that people like to compare it to is seasonal flu, seasonal influenza. And the key thing to note here is that it's significantly more transmissible than seasonal influenza. So on average, a person with seasonal influenza infects about 1.3 other individuals in the population. And this is the diagram of the seasonal influenza. Now, while that doesn't sound much, you just have to think mathematically again, that if I go through kind of 10 chains of, or 10 steps of transmission with this basic reproduction number, one case has infected about 16 individuals or so. If we go through 10 steps, 10 transmissions, from here we get to about 59,000 people infected. So just an illustration of how mathematics really highlights what these small differences actually do to the spread of an infectious disease. So what is this basic reproduction number telling us, and how is it helpful when we think about our response to the epidemic? R0 is not a fixed function of the virus. It's the virus and how the virus behaves, as well as contact patterns within a community. And essentially, it's a function of 3 things. It's a function of the probability of transmission happening if there is contact between an infected individual and a susceptible individual. Also, the number of contacts over a certain period of time, and the duration that somebody with the infection is infectious for. So this R0 is a function of these 3 things. So when we think about our response to the epidemic and trying to slow down the spread of the epidemic, this can help us because we need to think about interventions that are addressing one or more of these variables, essentially. So if we're to think interventions, we need to then understand a little bit about transmission and how this virus is transmitted between people, to start to think what those interventions might be. And this is where we get a little bit technical on the kind of medical epidemiological side. But this is where we're thinking, how is this virus transmitted from an infected individual to an uninfected individual? And essentially, it's by what we call droplet and contact transmission. So just to explain that, what you see here is an infected individual here in gray, and this is kind of showing the virus in the lungs of this individual. when this individual coughs or sneezes or just talks or just breathes, what comes out of our mouth when we do that is these very small, what are called respiratory droplets. And essentially, these are just tiny spatters of water that come out from our lung. And within these tiny spatters of water can be cells and can be virus. And there can be virus that can be infectious. What we understand is that there's different sizes of droplets that come out of our mouth. The larger droplets tend to just travel around a meter or so and are large enough to fall under gravity to the ground within that meter or so. There are smaller droplets then that are more dispersed in the air and that can hang around in the air for longer and be kind of disseminated more widely in the air. What we understand about this virus is that the predominant mode of transmission is via these larger respiratory droplets and not via these smaller droplets that travel further, that are more dispersed, that hang around in the air for longer. And that's the reason for the kind of recommendations around physical distancing, around keeping 1 or 2 meters apart from people, is that we're creating this space so that somebody who's infected, who's just talking to us or breathing or maybe coughing or sneezing, that we're less likely to be exposed to any of these larger droplets coming out of that person's mouth. What also happens is these droplets that come out of the infected person's mouth can settle on surfaces. And those surfaces can be a table surface, a door handle, an inanimate object of any sort, a phone, a pen. These inanimate objects that the droplets can settle on, we term fomites. And so if I then touch this surface or touch the door handle, these droplets with virus attached can get onto my hand. And if I then touch my mouth or my nose or my eye with my hand, I've then inoculated myself with the virus. And that is essentially the 2 ways that we think transmission is happening. We'll come back to that in terms of then thinking about the interventions that we've introduced. But one of the key things then is to understand, so who are these people in the population that are getting infected and that are most infectious, that are most likely to spread the infection to these uninfected individuals? This is just showing, again, the age profile of the cases, and this is from an early report from China. And it's really just to highlight that from early on, it was seen that this was predominantly an infectious disease that was being seen in adults. And what was striking here was in the younger children, they were not seeing many cases of this disease. So they weren't seeing children presenting unwell at hospitals and clinics with the infection. So the average age was around 50 years. And one of the key questions we've been thinking about since seeing this kind of data is, does that mean children are not infected, not affected by this disease? Or is it just that they are infected but don't become unwell? And I think that we now have reasonably good data that tells us that children are as likely to be infected as adults are. But they're much less likely to develop symptoms, to be unwell with the infection, and much less likely to have severe disease. So this graph is just showing a nice study from China where they were able to look at cases, look at people with confirmed disease, and then look at their household contacts, so people that they've been in very close contact with, and look at how many of those contacts developed the infection over the next few days. So purple is the proportion of people in these different age categories that got infected. And you can see that across the different age groups, it's roughly similar, that about 10% of people were getting infected with the virus. It was a little bit higher in the older individuals, but not significantly so. So they were just as likely to be infected, but much less likely to be unwell with it. What that's meant is that the big unknown for us is still to what extent these young children and even the older children and adolescents, to what extent they are responsible for transmission of the virus in the community. And I think we still don't know the answer to that question. The other thing we need to understand is, when is the virus transmitted and when is somebody infectious? And again, here this is a little bit technical, but we still think that transmission is driven primarily by people that are symptomatic, people that are unwell, that are coughing, that have fever, and likely in the first few days of their symptoms, because we know that's when the level of the virus in the respiratory tract is at its highest. But I think something that we've come to understand is that there may well be quite a bit of transmission happening in the day or two before symptoms start. So what we can show with data is that the virus is already at quite a high level in the back of the throat in the day or two before somebody becomes unwell. And so it's potentially, it's possible that those people are then infectious and are transmitting the infection before they're aware that they have the infection. In terms of how long somebody's infectious for, we think that may be for around a week, particularly in the kind of the mild to moderate cases of disease. Because we can show that although the virus is detectable by the main test that we use, this PCR test, which is just detecting the genetic material of the virus, that can be detectable for some time after the symptoms resolve. But it seems that a lot of the time that's not what we call culturable or viable virus. So it's virus that doesn't grow in the laboratory. And so it may not have the capacity to infect other people. And so based on that, we think transmission after 7 days of illness is probably uncommon. The big unknown, the thing that we're kind of desperately needing to find out and wanting to find out, is how common true asymptomatic infection is. So people that will not get symptoms at all, how often does that happen in the population? And to what extent are those people driving the transmission in the community? And we don't know this because we haven't yet done the studies to tell us how frequent asymptomatic infection is. And I think we're expecting to see some data from studies in the next week or two from China and elsewhere, because this essentially relies on doing antibody testing. So testing people to see that they have evidence that they were exposed to the virus, but they'll tell you that they never had any symptoms. And from that, you can get a good understanding of how many people in the population were infected but asymptomatic. And those studies are happening now. I'm going to just skip over that slide. So just going back to thinking about how it's transmitted, if we understand that, it gives some rationale to you behind the kind of recommendations that you've been seeing over the past couple of weeks about how we can do our bit to prevent transmission of the virus. So the first thing there is the physical separation. And so when you're told that we should all try and keep more than 1 or more than 2 meters away from other people, it's essentially for this reason that we said, so that you stay out of the range of these respiratory droplets that somebody might be expelling from their mouth. The measures that we call respiratory hygiene or cough hygiene, cough etiquette, that's when we say that you should cover your mouth and nose with a tissue, or if you don't have a tissue, with your elbow. And the reason for that is just to prevent, if you are infected, to prevent these droplets spreading in the area around you. So if you cough into the tissue, all the droplets go into the tissue, and if you put that in the bin, you've obviously prevented some of these droplets spreading in the area around you. And finally, what is probably the most important is the hand hygiene. And that's really about, if we assume that there are infectious people around us in the population, and that these droplets are sitting on fomites, on these table surfaces, on door handles, then what we need to do is to prevent, we may not be able to prevent touching these, but what we can do is prevent the virus then getting onto our mouth or our nose or our eyes. And that's by cleaning our hands, washing our hands regularly. And here soap and water is by far the most effective. Soap very quickly kills the virus. The virus is quite a weedy virus in a general sense, and it's very rapidly killed by normal soap. And so if we follow the hand hygiene, then there's much less risk of us inoculating ourselves with the virus. But essentially, one of the cornerstones of our public health response is trying to identify in the population these people that are infectious. So the people that have the infection and have the potential to spread it to other people. And the cornerstone is to identify those people and to isolate them, to separate them from the susceptible people in the population, as well as monitoring and keeping under quarantine the people that have been in close contact with them while they've been infectious. So that step, the detection and the isolation of people, relies on testing. It relies on having a test available that can identify someone with the disease. And it relies on you testing people that have the symptoms that are suggestive of this infection. And here this graph is just giving us a sense of how countries have done with testing. And so this is showing how many tests each country has done per million people in their population. And the numbers are not so important, but it's just to show what I said earlier, that there's really quite a wide range here of testing. And if we look at South Africa, we're here towards the bottom here, where we've done relatively little testing compared to some other countries. Now, this is a little bit of an unfair comparison because, of course, the epidemic really started at different times in different countries. And so we were much later to really start with the epidemic than other countries. And so we're kind of catching up at the moment with our testing. And this graph is already kind of week out of date. And we would now see ourselves kind of higher up this list of countries because the testing has accelerated to some degree. But just to give you a sense, we've done around 20,000 or just over 20,000 tests overall since we started testing around the end of January in South Africa. Most of those tests are actually in the private sector, with only around 2,000, 3,000 tests in the public sector. And just to illustrate how that compares, South Korea here, at the peak of their epidemic and their response, they were doing around 20,000 tests every day. So it gives you a sense of what some countries were achieving to help them control their epidemic. We're now doing around 2,000 to 3,000 tests per day. So as I say, the testing has accelerated in the last week or so. Just going back to our reproduction number, our R0, thinking about these different variables, can we do anything about the duration of infectiousness? Well, the duration of infectiousness usually relies on there being a treatment of some sort that can make somebody uninfectious more quickly than they would naturally. But the reality is we don't have an effective treatment yet. We don't have any treatment that we know to be effective against this virus. We have a number of drugs that are promising and that are currently in clinical trials, but none of these have been shown yet to be effective and to reduce this duration of infectiousness. There's been a lot of fuss around chloroquine, which is a simple anti-malarial drug that's been around for a long time. But actually, there's no good evidence yet that chloroquine is effective. And we wait for better quality evidence to tell us whether this is something that's going to be helpful to us. Again, startling fact of this epidemic is how quickly the science has happened. And here we show that already the first randomized clinical trial of a treatment for this disease is published in one of the leading medical journals. This was last week. And unfortunately, it had a result that showed this drug, Lopinavir-ritonavir, had no effect on the clinical disease, but just remarkable that we're already seeing randomized clinical trials reporting this early in an epidemic. So again, coming back to our R0, where we are now is essentially left with thinking that we need to reduce contact. We need to reduce people coming into contact with each other, because this is the main variable that we are able to influence at the moment. And so if we think about the initial steps of the South African response in terms of that, this was kind of after the president's announcement back on the 15th of March, I think it was, there was obviously kind of wide-scale public information campaigns to give people the messages around the hand hygiene, cough hygiene, the physical distancing. There were international travel restrictions, again to try and prevent more cases coming into the country from Europe, from North America, where the epidemic was at a more advanced stage. But what we know about that is once there's transmission happening in the country and spread happening in the country, these travel restrictions may have relatively limited impact on the overall epidemic, because you've already got transmission established in the population by this time. You'll know from the university that we closed the university down quite early and around the same time that the schools were closing. So again, the theory here is that the schools and universities is where a lot of people are in very close contact. And so what you want to do is to avoid that and avoid that being a driver of the transmission. Again, this comes back a little bit, how effective this is comes back a little bit to us understanding whether the younger children and even the older, the youth, are really driving the transmission in the community. And I think we don't know, but our assumption from modeling is that actually the young children are probably not responsible for a lot of the transmission. So closing down schools may again have relatively limited impact on the epidemic as a whole. One of the big things that affected us as academics, as well as in our social life, was cancelling mass public events. So recommending that people did not get together in large groups where they would be in close contact with each other. And again, this is just coming back to understanding the basic transmission, trying to avoid people being in the range where they could be exposed to the droplets from an infected individual. So these steps were taken. It's still early to see whether these measures were going to really have an effect, but we can discuss in more detail. But I think what I'm trying to say to you is we might expect these interventions to have a relatively limited impact for these different reasons. And so where we are now, as of midnight, is essentially in a lockdown situation. And here you're asking the majority of the population to stay at home, to shut down population movement as completely as you can. And this is to reduce the overall contact rate in the population. But clearly this is associated with significant social and economic costs. And one of the key things to understand here is that on its own, this lockdown is not going to end the epidemic. It's not going to extinguish the epidemic. What it does is it buys us time to get more prepared and to understand what we're dealing with, to get our health system ready. And so one of the things that we're trying to highlight at the moment in the war room is that we need to use this time very wisely. And the question is, what do we need to do over this lockdown period? Well, again, different countries are thinking in different ways and thinking what they need to do in their country. But to be honest, I think we don't pay enough attention to the people who really know what they're talking about. And these are the people at the World Health Organization, who really, I think, are doing a remarkable job in this epidemic. And I don't know if any of you listen to the briefings every second day now from the World Health Organization. But they're really worth listening to, because these are the people who really understand infectious disease outbreaks and how to respond to them. And they're getting increasingly irate with countries who don't seem to be paying attention to what they say. And I think this is just an example from a couple of days ago, where the Director General of the World Health Organization was trying to stress to countries that locking down society will not extinguish the epidemic. And this is exactly verbatim what he said. So you've created a second window of opportunity. How are you going to use that opportunity? And these are the things that he said. You've got to train your workforce, get your workforce ready. You've got to get a good system in place to find the cases in the community. You've got to ramp up your testing, have testing available. You've got to get your facilities ready where you can isolate patients, even facilities where you can quarantine people. And these are particularly important in our communities, where we think of some of the challenges of isolating people in rural areas, in townships, the challenges of isolating people when they live in very close contact with many other people, and refocus the whole of government on suppressing and controlling. So essentially, this is where we're at now in South Africa, is making sure that we use this lockdown period wisely to follow this guidance from the World Health Organization and to get ready for when the restrictions are lifted, so that we don't just see an acceleration of the epidemic as soon as the restrictions are lifted. So I want to finish there, and I just want to thank everybody, and apologies if I've missed anybody off this list, but to thank everybody in Francesco and Tullio's kind of joint team in this big data consortium that are really working very hard with this data and giving us these graphs and these visuals to understand the South African and the local KZN epidemic. And I want to thank my colleagues on the war room, particularly Prof. Moshabela, who leads the war room, who have really educated me and kind of the discussion amongst us as members of this war room is what is helping us kind of understand what we need to do in KZN to get on top of this epidemic. So I want to finish there and hand back to Francesco, and then maybe we start to have a look at some of the questions that have come through online.
Yeah, Richard, thank you so much for the presentation. It was really informative and brought us all up to date and up to speed with what has happened and what should happen, or hopefully will happen during this coming three weeks, so that we don't waste the opportunity of reducing the contact time. Richard, I don't know, would you like to go through the question and answers quickly, or do you want me to quickly summarize them, so that, because I'm a little bit worried about the time.
How long? I've lost track of the time.
No worries. I guess we still have a few minutes. Maybe we could give some feedback on some of the questions.
Okay. Yes.
I can try to pick some of the questions that you have not addressed explicitly in the talk. Yeah.
Okay.
One question that interests a few people is, when can we hope to have a vaccine for COVID-19?
Yeah, so I think this is the kind of most common question, isn't it? And a very, very valid question, because essentially we know that's what we're going to require to in the long term for this virus. But the reality here is that it's going to take probably at least 18 months until we have a vaccine that we know to be effective and safe, and that is being produced in the quantities required to give to people in all these countries around the world. So it's not going to help us in this phase of trying to control the epidemic.
Thank you, Richard. Another question that was asked is, out of the current data analysis and the comparison with the development in other countries, is it possible to sort of predict when we will reach our turning point, where we will start seeing an inflection in the increase of cases in South Africa?
So I think we get asked that question a lot, and I think it's very difficult, because I think our response has been different from many other places. And I think the action that we're taking is much earlier than many other places. If you remember the graph that showed when did countries lock down, often when they had at least a couple of hundred deaths in the country. And we're locking down before we've had the first death from this. So what's unclear is how much this lockdown is going to slow down the spread of the epidemic. But I just come back to the point that the lockdown in itself will not have the impact that it needs to have unless we do these other things during the lockdown.
Thank you.
So I think at the moment it's difficult to say when the peak is going to be in South Africa.
Yeah, I understand. Thank you. Some people were concerned about really immediate advice, like do immune boosters help individually to be a little more protected, or when should they start getting alarmed and go for testing? Can you maybe summarize in a few sentences some really daily practical advice for everybody?
Yeah, so on the testing, I think the key thing that there's some understanding about is that there's no reason to test for this virus if you are not unwell, if you don't have symptoms of a respiratory tract infection. And by that we mean cough, fever, sore throat, shortness of breath. These are the kind of cardinal symptoms of this infection. And so the testing is really primarily targeted at those people that have symptoms. And if you're admitted to hospital now with those symptoms, you will get tested for this virus. On the immune boosters, the key thing there is for most of the normal population, your immune system it should be in the state it needs to be to deal with this virus. So standard immune boosters that you can get at the chemist and things really have no role to play in an infectious disease like this. What is very important is the key condition that we mentioned that affects a lot of people in this country, HIV. And what is very important is that everybody should know their HIV status. If they don't know their status, they should be testing and making sure that they're on effective treatment for the HIV, because that's going to be critical in how your body handles this COVID-19 infection.
Thank you very much, Richard. Maybe just to conclude, maybe two more political questions. One is that has been asked is, how likely is it that our government will try to implement all the World Health Organization recommendations quickly?
So I'm optimistic because a lot of the things that are mentioned there are already happening, and hopefully will be kind of intensified over the next 3 weeks. So in the war room, we've been spending a lot of time on some of these things, and on getting healthcare workers trained, on helping the hospitals get prepared and set up their own plans for how they handle people being admitted with this infection, and a kind of strategy for the province for how the cases are handled. The testing, there's certainly a plan to ramp up the testing. So both from the laboratory side of having more testing facilities running, but also from the people doing the testing. There's plans to have more community-based testing, to have people go out into communities and find people that have symptoms and test them for the virus. Of course, there are huge challenges to doing that. So to what extent we're successful with that in the next 3 weeks remains to be seen. But the intention, I think, is good there. And I'm optimistic that we'll make some progress there.
That is very good to hear, Richard. Thank you very much. Maybe one last question to finish on an African note. How well are the initiatives to combat COVID-19 synchronized and coordinated on the African continent?
Yeah, very, very good question. There is coordination both through the World Health Organization and through what's called the Africa CDC, so the Africa Centers for Disease Control. And these are quite strong structures. And Africa, of course, has a lot of experience with dealing with infectious disease outbreaks, such as Ebola and other outbreaks. So there's a lot of expertise there. But I think it won't surprise you that a lot of countries are clearly in a much worse state than we are in South Africa at being prepared and being able to handle this infection. And I saw on Twitter just yesterday, I was reading some quite distressing tweets from a friend and colleague in Zimbabwe who was reporting what was happening there and how the first patient had died in Zimbabwe, essentially gasping for air without oxygen, with doctors on strike because there's no protective equipment for them at all. And I think that it's clear that there's still relatively few cases in many of these countries, but we have to be alert that in many countries that may be because the testing is not really happening. And I think that we need to be prepared for a kind of acceleration of the epidemic in many other neighboring countries. Again, my colleague in Maputo in Mozambique last night was telling me they've only done 30 tests in the whole country there, and they've got 7 cases now. So the capacity to do what we're doing here just doesn't exist in many other African countries.
Okay, Richard, thank you very much. And I'm a little bit wary now about the time, so I think that we will stop here the answering of the question. I'm well aware that there might be many more questions, but we will try to organize maybe another such event very soon so that everybody will have the opportunity to ask even more questions. So at this moment, I would like to thank Richard really very, very, very much for the presentation and for all he and his team in the UKZN COVID-19 War Room are doing. And I hope that none of you will have need for their services and support. I also would like to thank our UKZN ICS team, in particular Abdullah Sharif, who very quickly gave us the license to make this webinar on Zoom possible. Thank you very much, Abdullah, if you are online. I also need to thank Kimara Naika and Ilya Sinaevsky, who helped me set up and, and manage all this event, in particular the invitation, the confirmation, the sharing of the passwords, and so on and so forth. And also I need to thank all of you, the participants to this event, because we had, I think, almost 130 participants, which is quite a world record for our data breakfast, which indicates that there's a lot of interest for these matters at this moment. Yeah.
Francesco?
Yes, please,
Francesco? So, sorry, I just see one question here that I think is important, that somebody asking, is there a platform where updated data and graphs from the big data team will be available as the epidemic progresses?
Yes.
So maybe you could just talk to that.
Anything on the CRISPR website, there is a link to all the data that we have analyzed. Yeah. And maybe we can share the link with all the participants. We have all the email addresses, yeah, that we can do. So I don't have the exact link in my mind at the moment, but if you go on the CRISPR website, you should find it easily. Yeah.
Yeah. So just crisp.org.za.
Yeah, and then it should be there. Yeah. No, thank you very much, Richard, for mentioning that. Okay, then thank you very much again.
And if people. Yeah, if people want to send additional questions, they can email me either directly or at the COVID-19@ukzn.ac.za email.
Thank you very much, Richard, for offering that. Okay, then thank you very much, everyone. Have a good day, and in particular, stay safe and wash your hands. Yeah. Bye-bye. Thank you very much.